Good morning and good afternoon, and welcome to today's webinar, Vaccine Confidence and Black Communities, Where Do We Go From Here? My name is Bisola Jakutu, and I'm an infectious disease physician at Harvard Medical School, Brigham and Women's, and Massachusetts General Hospitals. Most of my work is focused on overcoming barriers to accessing care among Black individuals who are living with or at risk for HIV, and I'm a co-investigator for the study that we'll be discussing today. Before we begin, I have a few housekeeping comments. First, this session is being recorded through Zoom and will be made available on the CHIPTS website, which will be provided at the end of the meeting. Secondly, we'll be running a live Q&A, so we have enabled the chat function. Please, if you have a question or comment, we encourage you to chat in that question or comment throughout the meeting, and we'll ask them during the Q&A portion. Thirdly, after the first hour of the webinar, which will be recorded, we will have a 30-minute community discussion where we'll break into small groups. This last portion will not be recorded. And fourth, closed captioning is available. Please click on More and click on Show Subtitle. Next slide. Let me begin by introducing the members of our research team who will be presenting today. James Obuaji is a CAB member with the UCLA Center for HIV Identification, Prevention, and Treatment Services, otherwise known as CHIPS. Laura Bogart is a senior behavioral scientist at RAND Corporation. Lulu Dong is also at RAND as an associate behavioral and social scientist. Lucky Alexander Fuller is the founder of Invisible Men and is a CHIPS CAB member. Priya Gandhi is a PhD student at the Pardee RAND Graduate School. Brandon Harris is a senior project manager with the Primary Care Development Corporation and is also a CHIPS CAB member. Samantha Ryan, or Sammy, is a research assistant with RAND. And lastly, Terry Smith is the director of HIV prevention services with APLA Health and Wellness. Next slide. As we're all aware, over the course of the last year or so, there have been many webinars. So what makes this one different, and why would we ask that you stay all the way throughout the entire webinar? Well, during this webinar, we're going to focus on hearing community voices, voices of participants in the research that was conducted, voices of our diverse study team, and your voices, the audience. We'll start by presenting lessons learned from vaccine rollout that are relevant to current and future health issues, including the limitations of current efforts. We will also share some personal stories, personal reflections, and hopefully hear insights regarding the experiences of LGBTQIA+ populations, immigrant communities, and others within the Black community whose voices have not thus far been amplified. And we'll leave plenty of time for open dialogue and discussion. Next slide. Let's begin with audience participation. I'll turn it over to Sammy.
Hello. What percentage of Black individuals living in the US say that they intend to get vaccinated or have already been vaccinated? The correct answer is D, 61%.
Okay, next slide. So let's review that answer. Willingness to take one of the available COVID-19 vaccines has changed over time, but among Black individuals, willingness has been lowest compared to all racial and ethnic groups throughout the beginning of the pandemic, as when vaccines were available. The latest data, the 61% of Black individuals who are willing, are from the Pew Research Center's American Trends Panel, which is a nationally representative web panel of randomly selected US adults. Next slide.
What percentage of Black individuals living in the United States have been fully vaccinated as of April 25th, 2021? The correct answer is A, 11.6%.
Next slide. Okay, so let's review these data. As of April 25th, we have 17.8% of Black individuals who had received one dose of either Moderna or Pfizer vaccines, whereas 43% of the overall US population had received one dose. In terms of fully vaccinated individuals, 11.6% of Black individuals living in the US were fully vaccinated as of the 25th, while 26.8% of the US population was vaccinated. I would like to be very clear in regards to these data. Much of the data reported to the CDC is missing racial identification, and not all states and territories report the demographic data on vaccine recipients. So I really don't want us to focus in on specific percents here, but just to recognize and to sort of keep in our heads in terms of our discussion that there are clearly significant disparities and clear inequity in terms of vaccine access and uptake. Next slide. Since the beginning of the rollout of COVID-19 vaccines, much has been stated as well as written about vaccine hesitancy, quote unquote, within the Black community. I think that this discussion has in many ways overshadowed the fact that there are many access barriers, many of which were predictable and anticipated because these are the same barriers that have existed and persist in regards to access to other critical interventions. If we want to change this dynamic, we're going to need to focus on addressing the root causes of these access barriers, as well as low confidence and mistrust of vaccines or other health interventions by addressing structural racism. I'm hoping that we'll talk about this more during the community discussion, but right now let's turn to the actual study that was conducted, and I'll turn it over to Laura. Next slide.
Okay, thank you, Basola. So we conducted a study of vaccine intentions among Black Americans, and there were several parts to this study. We did a national survey with 207 Black participants, and we also did in-depth interviews with 28 Black participants. And that was from December 2020 to March 2021, when the vaccine rollout was just getting started and even prior to that. We also convened a national community advisory board of individuals who represent different Black organizations and subgroups and subcommunities, including people living with HIV, sexual and gender minority individuals, and immigrant communities. And several of the members of that board are presenting today. And so the 28 interviews that we did included 23 participants from that national survey that we did. And those 23 participants had previously said that they responded that they were not willing to get vaccinated or that they would not get vaccinated when the vaccine became available to them. We also interviewed 5 stakeholders from our National Community Advisory Board as well in these interviews. And we asked participants their perspectives about how to increase vaccination in Black communities and also how to address mistrust. And now we're going to present key ideas and recommendations from those interviews, as well as some quotes. So the next slide, I'm going to turn it over to James. Thank you.
So a key recommendation we heard is that messages around COVID-19 should first acknowledge past injustices and unfair treatment by the healthcare organizations and government, particularly as a root cause of mistrust before offering information around the vaccine. Next slide, please. For example, this participant's suggestion for acknowledging racism and mistrust is to say that we understand why you're apprehensive given the history of what has happened to Black communities in the past. So it's an acknowledgement of the past and not just moving forward after that. Next slide. Another participant noted that there is mistrust due to Tuskegee and thinking that the government doesn't care and treats people like guinea pigs or statistics. So these concerns need to be addressed up front in terms of whether the vaccine is safe and also if it has side effects. Next slide. Participants also suggested a need to disseminate transparent and clear information about the vaccine. For example, the information needs to be completely transparent, include both positive results from the clinical trials as well as negative results or side effects. And the information also needs to be clear and understandable in layperson's language. Next slide. For example, so this participant suggests that whoever delivering vaccine information should be fully knowledgeable, completely transparent, and should not withhold any information. This is one way to become trustworthy and being viewed as trustworthy by the community. Next slide. Here, the participant is saying that they wanted to know all the truth about the vaccine itself, like what's in the vaccine and what are the long-term side effects, and around access, like thinking about like, oh, is it free? So all this information should be transparent and readily available for folks who are thinking about making this decision of taking the vaccine. Next slide. And here, this quote illustrates how important it is to allow for community members to raise questions and how Q&A would be a preferred format for disseminating information because it allows a setting where you can not just ask questions, but you can also get answers to those questions. Next slide. Finally, this quote illustrates or further illustrates the need to allow for questions and answers and using accessible ways like phone calls to disseminate information. Now I'll be passing it over to Lulu for some more recommendations.
Thanks so much, James. So in addition to transparent and clear messages, our participant also indicated that there is a need for open discussion. For example, what James talked about, Q&A forums with trusted messengers. So these would be community leaders, trusted doctors and scientists, and well-known figures like celebrities. So it's important to allow the opportunities for people to ask questions and get their specific concerns addressed. So I'm going to turn to Priya to read through a few quotes.
Thank you. So as Lulu mentioned, our interviewees emphasize the importance of hearing from trusted messengers like local and faith-based leaders and doctors who could speak to not only their own experiences in deciding whether or not to get the vaccine, but also their experiences in actually receiving the vaccine, as you will see from this particular quote demonstrated on the slide. Next slide, please. And we also received multiple suggestions from our interviewees to leverage celebrities or other influential figures. For instance, the quote on this slide discusses rapper Cardi B, and to pair those individuals with doctors or scientists. Back in 2020, we saw something similar take place when NBA player Steph Curry partnered with Dr. Anthony Fauci to discuss important social distancing measures to prevent the spread and transmission of the COVID-19 virus. Next slide, please. And finally, many of our interviewees also suggested that additional emphasis be placed on the role of Black individuals in leadership in the vaccine research and development processes. For instance, many suggested that we further emphasize the role that Dr. Kazmikia Corbett played in the vaccine development process. And with that, I'll turn it over to Laura. Next slide.
Thanks very much, Priya. So in sum, we heard a number of recommendations from participants about how to increase vaccine confidence, including acknowledging structural racism and also mistrust before providing information about the vaccine, and developing clear and transparent messages that are tailored to each community separately, and also identifying trusted messengers within each community. We also heard across the interviews about the role of social networks and local communities and the people who are trusted to talk about the vaccine and disseminate information. For example, healthcare providers, faith leaders, community leaders, as well as others who are known at the local level and public health as well as in people's networks and immediate friends and family. People said that they would be more convinced if others they do know show that they haven't had adverse reactions to the vaccine, that they've gotten the vaccine and been okay. Longer term, however, we really need to be thinking about systems and institutional change to address systemic racism and increase equity, especially around vaccine and overall healthcare access. So next slide, please. So along these lines, interview participants made suggestions for achieving equity by increasing access to the vaccine. They suggested tailoring the approach by community, for example, providing easy access to the vaccine in both medical and non-medical settings. Next slide. So for example, this participant suggested bringing the vaccine to people where they are and also making transportation more readily available. For example, public transportation and free rides, free ride shares. Next slide. This participant also said the more the merrier in terms of sites to offer the vaccine. So more places for people to get vaccinated, non-medical as well as medical settings, because some people may not want to go to medical settings. For example, churches, supermarkets, pharmacies. Next slide. This participant also talked about non-medical community social service organizations. So for example, places where people could get other things other than healthcare, for example, food banks, and places outside of healthcare that might be more trusted. Next slide. This participant talked about vaccination within healthcare organizations as an opportunity to get people into healthcare who might not have a regular healthcare source, and also using that as an opportunity to get people to sign up for the Affordable Care Act at the same time. Next slide, please. So now I'm going to turn it over to Basola again. Thank you.
Thanks, Laura. So in summary, our study, as well as a number of other community discussions, other studies, webinars, have led to the following recommendations. First, the hardest hit neighborhoods or neighborhoods with the highest COVID-19 incidence should be prioritized in regards to vaccine access. Second, the people who actually live in those neighborhoods that have been hardest hit should receive priority access, and this is not currently the case. Thirdly, access should be simplified and seamless. And as Laura described quite clearly, many participants said that there should be many different types of access sites. And certainly there should be assistance with accessing those sites and making appointments. Fourth, this is really something that came out of our discussions with our community group. We really need good data, and that data needs to be collected and released, not just about race and ethnicity, but also about social determinants such as housing status, language, country of origin, sexual orientation, and gender identity. At the end of the day, these data will be needed to know how equitable the response has actually been. And in addition to these points, if we really want to achieve health equity, I think we all sort of agree that vaccine distribution should utilize the resources, including the human resources, within the hardest hit communities. This will build long-term capacity and hopefully sustainable infrastructure within these neighborhoods and communities. And certainly to do this, creating partnerships with communities is also essential, because you really do need to, as I said, sort of build long-term capacity and truly understand the needs within those communities. Next slide. Lastly, and I think most importantly, at least amongst our group and our discussions, communities themselves should really be leading the way. I'll turn to the next slide, and Lucky.
Right. So next we'll discuss examples of what the current initiatives are around those demographics that need to be touched. So one, we need to reduce access to barriers by offering the transportation, like we spoke about earlier, free shared rides, opening community vaccination events in local community-based organizations, and there are several access points that have popped up within the last week or so, or the last 2 weeks, including Trans-Latina Coalition's vaccine clinics for trans and non-binary folks. The LA LGBT Center has created vaccine clinics for LGBT seniors and their caretakers. They've there was a partnership between the LA Trans Advisory Council and St. John's Cathedral to provide vaccine clinics for the LGBT community as a whole. So these communities are definitely most hit by, well, the Black LGBT communities were one of the most hit and the most impacted demographics by COVID, and they were left out a lot of the vaccine equity conversations. And so we're now seeing a lot of the city and the county, as well as CBOs, link in with medical providers and cities to be able to provide those vaccine clinics and that access. I will turn it over to Priscilla.
Thanks, Lucky. Next, we're going to hear some personal reflections from our study team. Brandon, James, Lucky, and Terry will be our panelists. And I'm going to start by asking each one of you to reflect on our first question, which is, what has your personal experience around COVID-19 vaccination been? Why don't we start with Lucky?
All right, no problem. My personal experience with COVID vaccination was pretty seamless. I got a vaccine through my job, so I was able to access it differently than a lot of the folks that are in my community. So I want to make sure I preface it with that. A lot of our community doesn't have the same kind of access that a lot of us in the CBO world have, or in the corporate world.
Great. That's important point to make. James, would you like to go next?
Yeah, very similar to Lucky. I have the opportunity to work within an institution, a medical institution that provided vaccines for us. And so my experience was also seamless, but also within that process, being mindful that even though I do have this access, and even though I do have this privilege, because it's a medical institution within a university, I feel like an onus to kind of be sure to disseminate the information that I'm receiving from that university to others, because it's not readily available for everyone.
Mm-hmm. Thanks, James. Let's turn to Terry.
So my experience is very similar to James and Lucky. I was able to get the vaccine through my employer. And so it was a very seamless, easy process. I did access the public access point for my mom. I was able to get her vaccinated, and that was a little challenging making appointments and finding an available appointment. She lives in the city of Long Beach, but once we made that appointment, it was very easy to get through. So I was able to kind of see the other side of this process of someone who didn't have necessarily access through their job.
Mm-hmm. Thanks, Terry. Let's turn to Brandon.
Sure. And so my experience was a little bit different. I actually got my vaccine pretty early on, but it was on accident. I'm actually in Texas right now, and so I was affected by the storm that happened in February. But fortunately enough, I ran to CVS that day, and they had extra doses. And so like it was about 6 people in the store, and they were like, hey, we have extra doses. Is anyone interested? And then they would ask like what type of work you do. And so they saw that I worked in public health. I was able to get the vaccine, the first dose. The second dose was a little bit harder. And I actually really went through a lot to get the second dose. I signed up on the county because CVS didn't promise a second dose with the first dose. They let me know that I may have to seek the second dose from the Dallas County. And so I signed up on the county. I got an email. I went to the space, the line at the fairgrounds. I waited an hour and a half. I got to the front of the line. They told me because I received it at CVS that I could not get it from the county. And so I literally had to go back to my CVS and beg and wait and get on a wait list for the second dose. And so it was a little bit harder. And so, fortunately enough, I had systems and, I know how to work the system, but I could see how if I was someone else who didn't know how to call or go to different places, or if I didn't have transportation to get to these different places, that I possibly would have given up and not gotten my second dose. And so I definitely see how, it could be a barrier for people to get one dose somewhere else. I mean, in state lines or different stores or anything, and then not be able to get their second dose.
So you bring up a number of issues regarding access as well as your abilities to sort of navigate the system. Let me just probe a little bit more deeply just to find out, how do you think it should have been different? What would have been a better system?
Yeah, I think, because CVS kind of said that once you get a dose and you have your, the card, the CDC's card that shows that you have a dose, that you should, I think once you're giving one dose of a vaccine, specifically Pfizer or Moderna, that you should be able to receive your second dose regardless of where you get that dose, if we're really moving towards people being fully vaccinated. And so I think that that's one thing that could come from the CDC, could come from the administration, is that once you get a dose somewhere, you should be afforded your second dose. That was one of the first things. I think the second thing was, CVS knew that they were going to get second doses. And so they could have said, when we get our second doses, we want to make sure that we have a full day's of schedule worth of people so we don't waste doses. And so once we are able to secure enough people for one day, we will call you back instead of leaving, because a lot of people were in limbo. When I got there was a list of like 30 people on the sign-in sheet, and they decided one day to kind of call in everybody and give them a time slot, but there was no organization to how that process went initially. So those are a few things for sure.
So a lot of that just sounds like communication, and lack of communication.
Yeah.
They could have really streamlined the process right there, just talking to people.
Absolutely.
Yeah. Have others heard similar stories? Anything that's similar to that just would have been addressed like by better communication, clearer communication? Because that was something that came up in our study. Lucky, I see you've unmuted.
Yeah, actually, I did have that experience with when I tried to get my wife vaccinated. So there was a lot of communication, and we went one place to get her vaccinated, and then they set the appointment, and then they left the appointment, and I was like, okay, we have to figure this out. But then we got another appointment. It was the Johnson & Johnson, and we know all of the rigmarole that happened with Johnson & Johnson. And so she was like, no, I don't want to do that. And I said, I understand. And so luckily for me, they opened up the vaccination through my employer. I work with the LA LGBT. So they opened it up to partners of employees, because, working with the senior center, we got vaccinations the first round. And so they opened it up for our partners as well.
So many of us are lucky, because I was also vaccinated through my employer, but there are many of us who are unemployed, and who don't have access in that way. So maybe we could talk a little about how this should be working for folks who don't have that access through their employer. Any thoughts about ways that we could increase access and for those folks who just don't have that kind of simplified, or not, maybe it wasn't all simplified for everybody, but who don't have that access?
Well, I think it's about the communication that we were talking about earlier, letting folks know that, it's free, that you don't have to have a job, that kind of thing, and then really making sure there are access points for those people to go to, that it's in their community, that their hours are appropriate, that there's free ride share. And so making it as inviting as possible, making sure people have full information so that they can access it.
You mentioned something, Terry, there about hours. So how much have you all heard about the hours of operation of some of these sites? Has that been an issue that's come up?
I recall, I think one of my friends, I think in California, had to wait in line, and after they basically got to the front, which was like at 5, that it closed. And so I think that it kind of goes in line with what Terry is saying with the whole kind of accessible and also meeting people where they're at. Because if people are doing full-time jobs and are these essential workers that are actually doing the essential work, like there seems to be a disconnect in, oh, we see these folks as essential workers. They might not have access to the vaccine, but we're not going to make it in a time that's like feasible for them to get the vaccine. And so there was all these kind of disconnects, especially with the time, that I think as time went on, these organizations started to make more widely available times because they I feel like they saw the impact and then course corrected, which I think is a good thing. That course correct aspect of it is really important throughout this whole process.
Any other thoughts in regards to issues regarding either just the time or the inaccessibility, or kind of what you all have seen in your experiences?
Right.
I was just going to add to the. Oh, go ahead. Lucky, sorry.
Okay.
No, I was just going to add to the. Oh.
Lucky, why don't you go first? Lucky, let me direct. Lucky, you go first.
All right. One of the things that I did notice, and I'm super appreciative of, was the faith community and the way that they showed up within these different communities. So it created access points for folks, but we also have to realize that a lot of folks within the community that I represent around the LGBT community don't frequent churches because of the different discriminations and things that they've dealt with within religion itself. So I think that is definitely good that not only did the faith-based organizations create those access points, but also still LGBT organizations also created that access as well.
That's great. We'll talk about some of those issues in a moment. I wanted to get Brandon's thoughts because you were just about to say something.
Yeah, it was just related to the time. And one thing that I was going to say is I think that compared to the county sponsored vaccination sites, it seems like pharmacies open later, like they typically run hours to 7 or 8 o'clock in the evening. And so that was something that was helpful, is when I did get an appointment, they said you can come up until 8 p.m. today, versus, some of the counties that ended at 5 or 6 in the afternoon.
Okay.
And I just wanted to add quickly to support James' point that I think that the rollout initially was quite rocky here in California, but it seems like people learned along the way and made changes and course corrected, which I think made all the difference in the world, because there were sites are open on the weekends and later hours and better communication. And so it was nice to see that the system was learning from itself and correcting to make it more accessible for people.
Great. That is nice when that does happen. So let's turn to another question. What role do you think that intersectional identities play in either perceptions of the vaccine or in this issue of access? Lucky, you had already started talking about maybe working through faith-based communities may not be the same experience. So other things that may be unique or that we need to be thinking about as we try to increase access to everyone. Lucky?
Yeah, like I was saying earlier, around creating those access points and being cognizant of how different communities function and navigate through the world, right? And so when I saw that there were more CBOs that, came into the community and said, and recognized that and realized that a lot of trans folks or a lot of LGBT folks won't go to maybe the church sites or may not go to medical sites due to medical mistrust around, all of the things that they've dealt with within the medical system. There were a lot of other sites like parks and different organizational sites that folks had popped up to make sure that those communities had that access, when before it wasn't a thing. And we know that, looking at some of the data, that Black LGBT folks were impacted. They were one of the highly impacted communities within the epidemic. So it was definitely necessary to make sure that those folks were vaccinated as well, or at least had the opportunity to vaccinate.
Absolutely, and understanding that different strategies work for different communities. We can't just use the same sort of thing and assume everybody's going to, sort of fall in line. James, do you want to weigh in also?
Yeah, I mean, I think I echo everything that Lucky says, and I think the two intersectionalities that I pay special attention to during this process is those folks who have pre-existing conditions, and also the aspect that Black people are not a monolith. And so, like, my parents are from Ghana. The way they receive information is different from the way that other Black folks receive information. It's like this kind of community village kind of component where you pass information within each other. And so I remember as I was like talking to my parents about getting the vaccine, there were there's a lot of hesitancy around it just because of the information that not that we're getting from like science journals or webinars or from Dr. Kizzy, but like from their friends that like watch CNN or watch this like the TV show. And so I think the dissemination of information really affects that kind of like that stepping point of someone deciding to get the vaccine. And then the pre-existing conditions, I think that that intersectionality I was fairly interested in because we know that when we talk about clinical trials, there's a lack of diversity in the folks that are part of that group. And so, and within that lack of diversity, it's sometimes folks who have pre-existing conditions. And so thinking about like, oh, how is this vaccine, whether it was Moderna, J&J, Pfizer, how's that going to interact with something that I've been living with my whole life, and where do I get that information? And so I think that information aspect was interesting during that process.
Mm-hmm. Mm-hmm. Thanks, James. Why don't we get a thought from Terry also, if you'd like to comment on this in terms of the roles of intersectional identities, and then I'll also ask you, Brandon, so you can prepare your. Go ahead, Terry.
At least you got preparation, Brandon.
Right. I'm just trying to free flow.
I think that it really all did play a role in people's perception. You talk about Black folks, right, and some of the mistrust of the medical system. And so how do we address that and acknowledge it, and at the same time kind of make sure people are informed and able to make a decision? And so I think that as we're kind of rolling out systems, we really need to understand the intersectionalities for folks' lives, and then design systems that kind of address those and meet them where they are.
Mm-hmm. Mm-hmm. Absolutely. Brandon, any thoughts?
I won't add anything because it would be just echoing what everyone else has said.
No, I think that all the things that were mentioned are really important. Let's turn to another question. So, there are a number of strategies, initiatives that have been designed to increase vaccine access. This use of trusted messengers, celebrities, YouTube, interviews and whatnot. There's a lot of stuff that's happening. What do you think, in your personal experience, is working versus maybe what's not, and what are the limitations of what's happening? So let's start with Brandon here, and then I'm actually going to ask everybody because we have a little time, available to get everybody's thoughts.
Yeah, so I mean, one of the things I would say for myself and my folks that I know is the frequency that we're seeing Dr. Fauci now compared to before. I think that his transparency, even with the J&J situation, him being transparent enough to say, this is science, this is working, we're looking at it, we're going back to the table, we're making sure we're going to come back out and and change things. I think the celebrity presence, the Facebook things that are happening when you get on Facebook, it like has the thing where if you got vaccinated or you can see celebrities getting vaccinated. I think those things where people frequent in social media and television and media are working. But I think that when you take that and you put it, the person goes to just like the communication we talked about earlier. So I think that the communication between people and health services and empowering patients and individuals, I think they get that empowerment when they see it on Facebook or somewhere. But then when they get in front of that white coat or the person giving them the shot or the negotiation, that kind of diminishes their empowerment. I think that still, both racism and the distrust in the medical system are things that are not working. I think that the lack of data with Black populations in the efficacy or the safety in the vaccine, and not just Black populations, but like trans folk and like people who are, I'm sorry that Addison is squeaking his dog toy in the background with me. But all of these things contribute. And so I will go on mute because he's going to have an attack at this point. But those are some of the limitations that I think exist still within the rollout.
Great. No, thanks, Brandon. Terry, would you like to weigh in?
Sure. So I think that one of the things that concerned me was about kind of the demonization of people who were not taking the vaccine as quickly as you wanted. So this whole kind of vaccine hesitancy, where you're almost like demonizing people, like you're dumb, what's wrong with you, why don't you take it? And it wasn't even kind of appreciating the context of structural racism, the mistrust, all the stuff that we talk about all the time. It was like, well, yeah, that's that, but I need you to take this vaccine. And then I think I was also concerned that there was this push to get people to take a vaccine as opposed to making sure that people knew why it was important so that they can make an informed choice. So not just stabbing people with a needle saying next, and although if I was king of the world, that's what I would have done. But I think at the end of the day, it's really about people having information so they can make a really informed choice. And then I think the other thing that concerned me is that we're vaccinating people, which is great. And we're talking about vaccinating the homeless and vaccinating all these folks, but the homeless person is still homeless. And there are all these conditions that are happening that are in people's lives. And so, yeah, they don't get COVID, but they don't have a job, or they're struggling with substance use, or they're homeless, or the list goes on and on and on. And so I wish we could have put these vaccination efforts in the context of larger social services so that we can address the whole person.
Absolutely. I was going to do the same clap on that too. What I don't understand is you have people sitting there for 15 minutes, maybe even 30 minutes after they get vaccinated. Why are we not screening people for social determinants issues? Why are we not referring people, linking them to care? It is, some people are trying, but the reality is that is like a captive moment, we don't see those. So Terry's point, your point is right on target. I really appreciate that. Other thoughts? James, do you want to weigh in?
I think that you hit the nail on the head with these missed opportunities. We know that within these communities that we're trying to make sure that they get the vaccine, there's a lot of different ailments that kind of affect their decision to even go to a clinic, like food insecurity, housing insecurity, mental health. And it's like all these different things that I don't think we're really taking into consideration, only because people just wanted the folks to get on the vaccine. We wanted herd immunity. We wanted to just get there quick, But I think that it was important within the strategy to kind of think about these underlying themes that could affect someone getting the vaccine. And so I think that limitation was that it was just so the process seemed so quick in terms of just I think one thing that I saw was getting Black doctors to be the face of getting people in the Black community to get the vaccine. But it was well, what about all these other issues? It's good that it's easier to do something where you see yourself in that action. But there's all these other components that should have been taken into consideration within that process.
Absolutely. Thank you, James. Lucky, did you have anything you wanted to add?
I definitely want to echo what everyone else, especially what Terry said around a missed opportunity to plug folks into services, because a lot of this mapping is being taken from the HIV mapping, right? Around how do we deal with this, right? So if we're going to be vaccinating folks, I think that we should be also testing folks for HIV in that same moment. There's so much time there that you can utilize, and that moment could change a person's life, right? So you make sure that they're vaccinated, make sure that they're also tested, and now they know their status all the way around. And I think that should have been one of those things that was implemented within the vaccination in some of these different sites. But I definitely appreciate the way that because the trans community is fairly small in comparison to the rest of the community. So some of the things that I saw working was folks talking one-to-one. So having those conversations with each other, and that being a driving factor for folks to be able to make that decision, right? Because we know that based on the folks that you hang around, those are decisions that you're going to most likely make, right? So I definitely appreciated that part, and I think social media played a really big part in that as well.
Thanks, Lucky. So before we move on to audience Q&A, I really wanted to first thank you all, but then I wanted to ask you for sort of final thoughts. We're all HIV people, you know what I mean? This is the work that we've all sort of done over time. And I just wanted to get any sort of last words of advice, wisdom, that we can almost sort of say this should have happened differently. We should have learned from what the work is that we've done. And I know Lucky already mentioned a few really important thoughts about also doing HIV testing, probably screening for people and offering them PrEP, all sorts of different things that could be happening. Is there anything else? And I won't call on anybody. I'll just say, is there anything anybody wants to add to that from your collective experience?
Well, what I, as someone who's done this work for a very long time, I was really impressed with how Black folks stood up and said, okay, we want to make sure that we get this in our community, right? And there was no kind of debate, like, let's do this. And I saw fraternities, sororities, a wide, diverse group of our community coming together. And I thought, what if we had done that around PrEP? What if we had done that around HIV, right? What if we got that minister to kind of get beyond the whole, homosexuality is a sin, but like, I don't want these people to get HIV. So let's just embrace this and let's address this as a community. And so I'm hoping that as we kind of get past COVID, that some of the things we learn is that we can't just address the issue without kind of demonizing the person or the behavior, and just address the issue, because it was just so, I'm sitting on calls hearing ministers just really about COVID, and I'm just like, but what about PrEP? What about this? What about that? And thinking back to those days of just really kind of battling with people about HIV testing and STD and why it's important. Yes, there are gay people in our community. Yes, there are different people in our community and all the other stuff. And so I could go on forever, and I won't, but I think you guys got my point.
What you're saying is absolutely on point, and it's the message that we would like more people to be hearing. We need that advocacy. We need to be all in this together, James, I saw you on mute. Did you want to add something?
Yeah, I think that with this epidemic or this endemic, and with all these other kind of different infectious diseases that we've dealt with, the information has always been out there. And I think that in this process of kind of getting folks to take the vaccine or to protect themselves, we approach this from a proactive we approach this from a reactive, actually. We approach this from a reactive kind of standpoint when we should have been proactive. Like, we had all this information. We knew that these communities were being affected at disproportional rates, but all of a sudden it's in the news and it's like, oh, surprise, but it wasn't a surprise, like, we knew this. And so I think that moving forward, it's kind of using this information that we already know to kind of create campaigns that are more shaped around the status quo and bettering that.
Thanks, James. I really appreciate that. So Brandon, would you like to say a few words?
Yeah, the only other thing I was going to add was the stigma that, that weaves through both COVID-19 and HIV. And like, I've tried to be very careful with stigmatizing the Johnson & Johnson vaccine, because it's still a vaccine and still available, but like the options of prevention that people choose, just like with PrEP, people choose to use PrEP and they have condomless sex. Some people are choosing to be vaccinated and not wear masks. So I think that I think some of our messaging, and it's coming from the top, obviously, but some of the messaging that we have around vaccine choice and, at this point, mask choice, with some states saying not to wear them, or people saying that you can not wear them outside. And I think that people are still, feeling some sort of stigma when they take their mask off and they're outside in places that have had masks on outside. And so just being mindful of the way that we interact and judge people and things like that.
Absolutely. And those are very wise words, and we should apply that across the board. We need to be mindful of our own stigmatized beliefs. We obviously need to be advocates. We need to work together as a community, and certainly being comprehensive and understanding that people are dealing with a lot of issues, that we can't just deal with COVID-19. There are many things that we need to deal with as a community, and certainly COVID-19 should also open up opportunities to deal with all those other issues. So all of those thoughts, I appreciate you all's wise words, and I appreciate your participation in this study and on this panel. Let's turn to some audience questions. So I'm going to pose them, but I would also like the other participants on the study team to turn on their cameras so that everyone can participate in answering questions. Okay, great. I think everyone is, or we can get everybody spotlighted. Okay, so I think this is actually a great question for our panelists, because they're asking about messaging and they're really speaking to some of the questions or some of the issues that were already brought up. So this person asks, how can public health improve messaging regarding second doses moving forward? In other words, there seem to be gaps and barriers and then people sort of dropping off the continuum, if you want to call it that. And we sort of know that issue, right? So what do we do differently in terms of messaging? How do we increase the rate of people's return, decrease their confusion in regards to returning? Because people always have, questions or are not sure when, they're supposed to return. So any thoughts, just let me know who wants to handle that. Lucky, would you like to go first?
Yeah, so I know that that with my experience with my wife getting vaccinated, she went down there, they gave her a card, and it literally had the date for her next appointment on it. I think that is the simplest thing that folks can do, is make that appointment for the second dose right then, right there for folks, even when they make the appointment for the first dose. But also when it comes to messaging, make sure that messaging is not just go get vaccinated. It's make sure you get the first and the second dose, and explain to people why that's important. Right. So people may feel like the first dose is enough and I don't feel like dealing with it. And, at least I got halfway there. But we need to explain to people why it's important. Right. Why is the second dose important? Why is it important for me to keep this appointment? And all. So if we urge and really stress those points, I think that could be effective.
Absolutely. Thank you, Lucky. Any other thoughts?
I would just offer also that I think it's important around the messaging around the second dose, because there's so much information, like people get that second dose, and oh my God, you're gonna die. You're gonna, it's gonna be really horrible. And I think it's important to talk about side effects, but also kind of put them in perspective, right? Because I think a lot of people get scared from getting that second dose. And much like Lucky talked about with my mom, we went through a county system to get her signed up. They gave her a card. They also, because I register online, I got multiple emails and texts like, come back, come back, come back. So that was very helpful in terms of just the follow-up to make sure that we got the second dose as well.
Absolutely. And then one of the participants in the audience said, make the appointment, which was already stated, text them reminders, but also feed them, realize that people, may be hungry. They may have other things that may be stressing them out and may have reasons, not to make their appointment. So you may need to offer incentives in a sense, and I think that has been discussed by other folks. That's certainly an option. I think people are already using some of those ideas. So I appreciate that. I wanted to ask a question about the study, and this actually wasn't brought up by an audience member. It was actually, I was describing the study to somebody outside of this group, but somebody who's doing the work. So what do we think we need to do next in terms of the research? Where should the research go? What is it we don't know that hasn't already been sort of, delved into it thus far? And I'm going to ask this of Laura first, and then other folks, please weigh in, because I think hearing voices of other people as to where research should go is really critical. Laura?
Thank you, Priscilla, and also thanks to the great panel. This has been such a great discussion. In terms of where the research should go, one thing is that we asked a lot of recommendations. We also saw a lot being done out in the field and grassroots organizing, but we haven't actually tested, what is the best approach for doing this, or what are the best series of approaches or multiple approaches. So taking some of these recommendations and actually using them, creating better messaging, thinking about what we need to do, for example, around the second dose, which, yes, we've heard very little messaging around that, why that's necessary. So actually going out and doing a test of what messages work best, and also what kinds of access points worked best, looking at the prior data and then doing a test and setting up a test of different kinds of access points against each other.
Great, thanks, Laura. Other thoughts?
I think that other data that could be kind of gleaned from this community, or other research that could be done, would be, how does the vaccine, how does it do with folks, like versus in different racial ethnicities? You know, how do they respond to it? Are there things about the vaccine that maybe we can improve in different communities? So, you know, for like the trans community, those folks that are taking hormones, what does that look like when they take the vaccine, and how are their bodies responding to it? For, you know, different folks, there are different factors for different racial ethnicities. How does the vaccine respond to them and those different factors?
So I think that's great, Lucky. Those initial phase 3, the large studies for the different vaccines, you know, the data that we have from them, it's clinical trial data. So it's within certain confines, right? And over, you know, a well-defined period of time. I think that your point is well taken, that we need to follow people long-term and sort of see what happens if they're, you know, we look at side effects and so on and so forth that may, you know, that may arise. I mean, certainly we do need to look at that, as well as being able to stratify by groups like transgender individuals, other groups that, you know, weren't necessarily looked at clearly, and there weren't enough of them necessarily in the clinical trials. That's also, I think, part of the messaging, you know, telling people, you know, what we know versus what we don't know. You know, I think that is really important. Any other thoughts about the research that we need to do?
I just want to throw something else out there. So around the research, I think we should be very clear and very transparent about the data and why we don't have specific parts of that data. That way we can get more buy-in from the community to say, okay, well, if we don't have this data, then a lot more of that particular community may come out and say, hey, look, I want to show up for that clinical trial, or maybe I want to show up and make sure that you have that data, right? We want to make sure that we're very transparent about the results as well.
Absolutely, transparency is key. So there's a question here that I think is important, given maybe one of the questions we asked during the panel. Do we have any national or local data on the COVID-19 vaccine uptake and structural inequity or structural inequality among Black immigrants, so non-US born Black individuals? So I would love to hear if you all know of anything. I myself do not know that anyone's collecting country of origin or region of origin data in regards to COVID vaccine uptake. Somebody might, but I don't know of it. I would say that one of my colleagues, a mentee of mine, did collect some data looking at these issues of vaccine confidence within non-US born Black populations. Most of them were African born individuals, and most were from the Northeast. But what he found was that many of the same issues that we've talked about in regards to vaccine confidence were similar, but some of the interventions might be different, like, you know, really looking deeply at who the key messengers are in those particular communities. I think you have to understand where people are coming from, where they're getting their information, looking at WhatsApp, because that tends to be a way that, James is nodding his head because it's something that African-born individuals and other folks from other countries use more frequently, possibly, than other modes of communication. And this, I think, relates back to Laura's question, that we need to understand what the message is and what the messaging channels should be. So I do appreciate that. But if anybody knows of any specific data regarding uptake, please put it in the chat and I'll mention it. I'm just trying to see what other questions we have here. A lot of, okay, so there's, I see there are a number of hands raised. If you could just chat your question in the box, and I will answer, or I will pose it to the audience, or pose it to our panelists. Okay, so this is a good, let me read this one. So this person is curious about what panelists think about using strategies that are about using social networks, peer leaders, sort of influencers online. How well is that working or not working to help increase trust, decrease stigma, increase uptake of vaccinations? Thoughts about this question?
I think that is really important, more so than any messaging or whatever, that people are talking to their neighbors, their lovers, their friends, that it's just old school communication, getting the message out there. So I think it's very, very important that we tap into social networks and use influencers to get the message out, because I think a lot of times they have credibility and trust that those of us who are not part of that community don't have.
James, did you have a response?
Yeah, I think that that approach is great. I would also kind of push the envelope on making sure that those efforts are coupled with with someone else, with a Anthony Fauci or with a Dr. Casey, so that we know that the information, I don't want to say it comes from a trusted source, but it's it has the background and the data along with it. So I think that's important to kind of couple the two to make it more advantageous for the folks who are listening.
Great. So I'm going to ask one last question, and then we'll turn to our community discussion and sort of open it up. We've talked about this issue of vaccine confidence and quote unquote vaccine hesitancy. I sort of, we know what the data shows and what the polls show, but from you all's own experience within your own network and what you're hearing, how much of a problem is it? Do you feel that it certainly has changed over time, but what more is there that we need, what more effort do we need to put in there? How big of a problem is it? I would love to get you all sort of just your thoughts off the cuff on how big of a problem you think it is. Did I stump everybody?
I guess I would say
James?
that. I guess I would say that. How do I word this? I think that this came at a pivotal time when it was directly in line with us seeing how systemic racism affects those communities who are disproportionately affected with COVID. And so I think because that came hand in hand with the murders that were happening along with COVID that was happening, I think it was a unique opportunity to make sure that it was done right this time, with that knowledge of this overarching and overpowering system of racism, and how we can use that and kind of view it through that lens in order to get to a solution-oriented way of getting to a solution.
Other thoughts?
Just to dovetail on what James said, it also showed us a lot of gaps. It showed us what it looked like for Black folks in the medical facilities. It showed us where those inequities and lie, even beyond COVID with HIV, it showed a lot of things. So it definitely, it empowered us because of the place, like James said, we were in socially, right? But it also showed up a lot of gaps in a lot of different ways. And it showed us how hard it was going to be to get our community to really understand that the vaccine was necessary. But it really really brought back why it was hard to get our community to understand it was necessary. And that was one thing that we definitely got to see, was folks really showed up and said, before we take this, we want to know, one, is it for us? And is this another experiment, or is this, what is this? But it definitely brought to light a lot of the other inequities that showed up.
Absolutely. It really, for me, amplified what was already known, not just with the disparities, but with the questions that we have, and the questions that really deserve to be answered. It's not like something we can just glaze over. I mean, we're in the middle of a pandemic. We want the answers. So I really appreciate this opportunity to talk. I really appreciate the audience questions. And thank you all. I think we should probably move on to the community discussion, which will be led by Lucky. Thank you all so much.
All right, so we're getting ready to jump into our community discussion portion. CHIPTS is going to randomly place folks into rooms, and if you don't see the join button when you get ready to be placed into rooms, then give us a second. Someone will give you a help. So we're going to, once you get into the rooms, identify someone in the room that will note take and report back. The chat rooms will not be recorded. And so we're going to have a couple of questions within the rooms. One question is going to be, what recent efforts and policies have you found successful in increasing access and willingness to get vaccinated? Another question is going to be, what lessons can be learned from community-based public health initiatives, increasing PrEP access for those living with HIV? And another question is going to be, what further efforts to increase inequities around COVID-19 are needed, especially to reach subgroups of Black communities with intersectionalities like trans, LGBTQ, immigrant communities, those living with chronic health issues? And so there's going to be a facilitator within each room that we're going to have folks in to kind of help the conversation along. And so give it a second and you will all be moved to rooms. And if you look in the chat, the questions are there. Are we ready to go to rooms?